Welcome. A diagnosis of delirium can be made when all four of the following features are present: acute onset, disturbance of consciousness, impaired cognition, or perceptual disturbance not due to pre-existing dementia. Clinical evidence of an acute general medical condition like intoxication or substance withdrawal. Two main patterns of delirium: hyperactive delirium, agitated and wandering; hypoactive delirium, quiet and withdrawn; and mixed. Both of them can be found in a patient. Two main patterns: hyperactive delirium, agitated and wandering; hypoactive delirium, quiet and withdrawal. Some patients may have features of both. The hypoactive pattern is particularly important because it often goes unrecognized. Diagnostic criteria for delirium. Symptoms are present in following area: disturbance of consciousness, reduced clarity of awareness of the environment, perceptual distortion, psychomotor disturbance, hypo or hyperactivity, unpredictable shift from one to other, disturbance of sleep-wake cycle, emotional disturbance, depression and anxiety. The differential diagnosis of delirium: dementia, depression, hysteria, mania, schizophrenia, dysphagia, seizure, temporal lobe seizure or non-convulsive state, epilepticus. The most important aspect of diagnosing delirium is to get a full history from someone who knows the patient. These are the differential diagnosis. Other diseases: abbreviated mental test. We ask the patient 10 questions. How old are you? When is your birthday? What time is it? To nearest hour. Can you remember this address? And give him his address. What year is it? What place is this? What is my job? What is that person job? Recognize. Can you tell me the year of the World War I started or finished? What is the name of the president or monarch? Backward from 20 to 1. 10 questions. This is a validated test. Therefore, asking any 10 of your own questions is not necessarily valid or reliable. Half marks are not acceptable. A score of 8 or more is normal. Management of delirium. Prevention. Those at high risk for developing delirium can be targeted for proactive care aimed at preventing it. Some risk factors, but many in the list of precipitating factors can be other factors, including environmental ones, are also important in the prevention and management of delirium and are listed. Detection. Half of all cases of delirium go unrecognized. Detection is more likely in those with difficult behaviors. Routine cognitive tests will not in itself identify delirium, but will alert the clinician to the presence of cognitive impairment and trigger further questions to differentiate delirium from dementia. The confusion assessment method is designed to be used by any clinician. Confusion assessment method. To have a positive CAM, the patient must display the presence of acute onset, fluctuating course, inattention, counting from 20 to 1, with reduced ability to maintain or shift attention, and either the diagnosed thinking, disorganized or incoherent speech. Altered level of consciousness, lethargic or stuporous, common drug group that can cause delirium in older people: opioid analgesic, drug with anticholinergic properties, sedating drugs like benzodiazepines, corticosteroids. Here some tests we use to diagnose delirium: full blood count, C-reactive protein, urea electrolyte, calcium. This full first line investigation. In our first line investigation, calcium, thyroid function, liver function, glucose, chest x-ray, electrocardiogram, pulse oximetry, urine analysis. Second line investigation, arterial blood gases, computed topography of the brain, specific culture for urine, for sputum, for blood, electroencephalogram, evidence of raised intracranial pressure. Determining the underlying cause. When delirium has been detected, an assessment to look for the underlying cause is the next step. Several different acute illness as well as medication can produce delirium in at-risk patients. Have at least two causes. Common cause of delirium: infection, acute hypoxemia, electrolyte imbalance, prescribed medicine, myocardial infarction, alcohol and benzodiazepine withdrawal, urinary retention, fecal impairment, urologic stroke, subdural hematoma, seizure, post-operative cognitive dysfunction. The history, physical exam, and inspection of drug chart will often lead to the underlying cause. Treatment. People with delirium should be admitted to hospital in order to facilitate observation, investigation, and the treatment. Treatment in delirium has four components: treatment of the underlying cause, environmental measure, pharmacological measure, prevention of complication. Treat the causes: infection, acute hypoxemia, electrolyte imbalance, prescribed medicine, myocardial infarction, alcohol or benzodiazepine withdrawal, urinary retention, fecal impaction, neurological stroke, subdural hematoma, seizure. The prevention and early detection. This is our scheme for dealing with delirium. Summary for prevention, diagnosis, and management. This treat the cause: infection, acute hypoxemia, electrolyte imbalance, prescribed medicine, myocardial infarction, alcohol, benzodiazepine withdrawal, urinary retention, fecal impaction, neurological stroke, subdural hematoma or seizure. Environmental: avoid overstimulation, avoid sensory deprivation, provide environmental and personal orientation, minimize discontinuity of care, encourage mobility, adequate fluid nutrition and sleep pattern, involve relative and carer. Pharmacological: stop drug that can cause delirium, use drug only as a last resort, preventing complication. Be vigilant about the following: falls, pressure sores, hospital acquired infection, functional impairment, incontinence, over sedation, malnutrition. In the prevention and early detection, all older patients presenting to acute medical service should have an abbreviated mental test. Consider delirium in all patients with a score at least than 8, especially those at risk. Thank you.